5.8 from 2.4. His C3 and C4 were consumed, and he had proteinuria of 3 grams per day. He had a previous biopsy 6 months ago, which showed only secondary FSGS lesions, 40% global sclerosis, and 15% interstitial fibrosis. So who is here is in doubt that this patient does not have active lupus or activity. So you all think that this patient has lupus activity. Good. So, and you are absolutely right. As you can see here, this patient had all forms of active lupus with subendothelial deposits, proliferation, and so on. Okay, so what information did the biopsy provide? You all knew that this patient had lupus activity, so why did we biopsy him? We biopsied him because the biopsy is going to tell you which class it is, the activity, possibly the activity and chronicity indices for this, whether the patient has crescents, fibrinoid necrosis, so whether you need to include cyclophosphamide, the percentage of activity, shall you go aggressively? He already has a history with 40% global sclerosis. Why is his serum creat 5.8? This cannot be explained just by the lupus activity. So something else is going on. Does this patient has an associated TMA? Is he already end stage? His tubular interstitium showed some neutrophils. So is there an associated infection? So now the biopsy had provided you with prognostic factors and with management guidelines. This was a 25-year-old female with a postpartum diagnosis of HELLP syndrome. She was an acute renal failure, initiated plasma exchange, and anyone is in doubt that this patient has thrombotic microangiopathy? No, and you're absolutely right. She did have an extensive florid thrombotic microangiopathy within her kidneys. So again, why did we biopsy? We biopsied because this patient did not have a good response to the plasma exchange. She was not weaned off the dialysis, and look at her arteries, and with this arteries, we can easily tell you that this patient is not going to respond, and there is no need to go on because her renal functions are going to deteriorate. So even if you know the diagnosis, like in thrombotic microangiopathy, there are other things you need to know, like site of involvement is important. It makes a difference whether it's glomerular only or whether the blood vessels are involved. Although we cannot truly identify the cause, but however, in most cases we can suggest it because you do have clues, as Ian have mentioned yesterday, which can tell you in which line you are going. So biopsy is important, even in clinically overt cases, as it would provide you with prognostic factors. Factors towards poor prognosis are glomerular involvement, more than 50%, if you have blood vessels involvement like the one I've just shown you, or if you have more than 50% cortical necrosis, usually these patients are not going to resolve. So because the biopsy should give you more information than the diagnosis, we have came with classifications, which you're going to hear very elegantly from Ian after me, but I just want to say the classifications are not only for pathologists. The value for classifications is to implement diagnostic information with prognostic indications and facilitate the clinical management. It can guide your therapeutic decisions. And that we have moved from an era where all our classifications were morphologically based, and so EM was played an important role, to an era where we are now, where we need classification based on etiology and pathogenesis, because this is what's going to guide our patients' management. And hopefully in the future, then we can integrate gene expression and profiles. So if you've got a morphological diagnosis, now look at these. What are these? Pyramids. They're all pyramids. But actually, they are not all the same thing. So this is the morphological diagnosis. Yes, they do all look like pyramids. But one is the Giza pyramids, the other one is the glass pyramid in front of the Louvre, the other one is just pyramids in Saqqara, and so on. So although they all look like pyramids, they are completely different things. And this is what happens with morphological diagnosis. Best example of this is focal segmental glomerulosclerosis. FSGS is a pattern. It's not a diagnosis. And FSGS do have now subclasses, which includes primary, genetic, and secondary forms. And although this differentiation requires really a thorough clinical pathological approach, the biopsy will help you to tell you that this is, whether this is a non-specific focal global glomerulosclerosis, whether this is focal segmental scarring, post-inflammatory or necrotizing lesions. Sometimes the variant of the FSGS carries a prognostic value, as you know, that we all know that the collapsing variants carry really a worse prognosis and a speedy deterioration of the renal function. With FSGS, actually, immunohistochemistry has no role in the diagnosis of the lesion, neither do EM. If we're trying to differentiate between a minimal change and FSGS, and if I cannot see the FSGS on light microscopy, then the EM is not going to help me. However, we still have to do immuno. This is mandatory in order to recognize that this is not a secondary FSGS to another glomerulonephritis, like membranous, for example, or that this is not a class 2 lupus with a secondary FSGS, and so on, or that there is no IgA nephropathy. IEM can help to differentiate, can help you together with the light microscopy, that we have some clues which can tell you probably in which line we're going, whether this is primary, whether this is maladaptive or secondary. Yes, in advanced cases we cannot differentiate, but in most of the cases we can give you a clue where we are going. So in FSGS, it's really important that you can go further than the morphological diagnosis with your pathologist, because a misclassification may lead to unnecessary administration of immunosuppression to patients who do not need it. Patients with secondary FSGS do not need immunosuppression. Patient with a genetic form of FSGS is not going to respond to regular steroid therapy. Another example of what we call just a morphological diagnosis is membranoproliferative glomerulonephritis. And this is the example of where we moved on with our classifications. Now, the older classification with electron microscopy changes is completely obsolete. We don't use it now. There is no type 1, type 2, or type 3. Now the classification, which is based on immuno studies, because this really what gives you an idea about pathogenesis, whether this is an immune complex mediated MPGN or whether this is a C3 glomerulopathy, because the management of these patients are going to be completely different. So this is another era where things changed. Of course, I'm not going to talk about IgA nephropathy in the presence of Ian Roberts, but I just want to say that this is one of the best examples of an evidence-based prognostic classification. And he's going to talk more thoroughly about this. I just want to say that this is a classification which is based on giving you prognostic clues for the patient, not to place the disease into categories or classes. It's all based on what has prognostic evidence, together integrating the immuno changes within it. And Ian is going to talk about this. The biopsy can also give you unsuspected findings, like this was a 37-year-old male who presented with hypertension, nephrotic syndrome, serum creat of 3. ANE and ANCA negative, his C3 and C4 normal, virology negative, and his serum antiphospholipase positive with a high titer. Surprise. What's this patient? Membranous. This is a membranous patient. Shall we biopsy? Yeah, okay, well. Yeah, well, they biopsied because his creat was 3, actually. And this was his first presentation. And look at the biopsy. Now, the glomerulus to the down the screen has a typical classic, very nice membranous GN. The glomerulus just on top of it has also a very nice classical thrombotic microangiopathy. So this patient had a serum creat of 3 because he had a superimposed TMA on his already pre-existing membranous, because he was not compliant to his hypertensive treatment, as I knew later on from the nephrologist. So chronic kidney disease and glomerulonephritis as MGN and FSGS can precipitate accelerated phase hypertension and thrombotic microangiopathy. These cases are not recurrent post-transplant, and hence when you get a patient like this, you have to identify why did this patient have actually TMA. But this is one of the main causes of unexplained deterioration in patients of glomerulonephritis. This is another patient which also had membranous. He had the same thing, but this patient did present with a creatinine of 4.5 and proteinuria 6 gram. And again, a positive antiphospholipase in the serum. And again, hooray, this is membranous with secondary segmental sclerosis and looked a bit chronic. But look at his interstitium. And his tubulointerstitium had actually schistosoma. So this patient had an unsuspected schistosoma hematubium infection, which only showed up in biopsy. So in membranous, phospholipase is really now mandatory for evaluation of any membranous glomerulonephritis. Whether you're going to do it on serum or in tissue, it's very easy. It's a very easy, reproducible, and very nice marker to be performed on tissue, whether IF or by immunoperoxidase. However, if you're doing serum phospholipase, if positive, you still need the biopsy for management and prognosis. You need to know the stage of chronicity of this patient, the degree of interstitial fibrosis which is there, the status of blood vessels, and whether do you have any form of associated lesions. And if the serum phospholipase is negative, it still could be positive in the biopsy because sometimes it just all precipitates in the kidney and it's not detected in the serum. This was a female patient, 70 years old, diabetic, and presented with a serum creat of 9.1 and normal fundus. She had, I think, an anephrotic range proteinuria and some hematuria. Her virology was negative, ANA negative, but C ANCA positive. And truly enough, this patient's biopsy showed all of these nice crescents and segmental fibrinoid necrosis, as you can see on the second picture, along with evidence of global sclerosis and some affection by diabetes, as Ian was talking earlier. Did we need to biopsy this patient? We needed to confirm that her creatinine was basically due to the ANCA. And we have recent evidence that prognosis in ANCA is related not only to the glomerulosclerosis, but also to the extent of tubulointerstitial fibrosis. And it's not only related to the type of ANCA, whether it's MPO or the other type. So you need to know the glomerulosclerosis, the extent of interstitial fibrosis, the extent of fibrous crescents in relation to the active ones, how much tubular atrophy you have, because these items were actually predictive of dialysis independence, and patients with a lower chronicity index have a better treatment response. And this is just to show you what do we mean by active, dual active. This is one glomerulus with segmental tuft necrosis and with segmental sclerosis, which is a common finding in vasculitis, in small vessel vasculitis. So you can have both going on at the same time. Well, I'm not done yet with this patient because so far that's regular. Well, her interstitium did not look so great. She's the same diabetic patient with the ANCA vasculitis, and I just felt there was something else going on with her tubulointerstitium, and her Congo red was positive. This patient also had isolated interstitial amyloidosis, which was positive for leukocyte chemotactic factor. So this was a very unfortunate patient. Of course, not your everyday scenario, but again, this is just to prove what this biopsy can give you on unsuspected findings. And this patient is not going to lose her kidney because of her diabetes, nor because of her vasculitis. She's going to lose her kidney because of her interstitial amyloidosis, because these patients deteriorate fast to end-stage renal disease. So again, just for the immuno, with the amyloid, now we have more than 30 types of amyloid proteins that are identified, and the earlier, again, very often used grouping into primary and secondary amyloidosis is not a useful classification anymore, and we should stop using it. We're not using it. Now a classification based on the main fibril protein is now used. So if it's a light chain amyloidosis, then this is what it's called. It's a AL, what was known as primary amyloid, so now it's an AL amyloidosis. If it's what was called secondary amyloid, then it's an amyloid A amyloidosis. So site of amyloid involvement is very important. Not all, if it's glomerular, if it's vascular, if it's interstitial, you need to be mentioned in the report so that you can explain the presentation of the patient. Patients with interstitial amyloidosis, as you see, the one here on down right, this is LAC2, this is immuno for LECT, and you can see that it's mainly interstitial, while the one above it, this is immuno for AL, and this is lambda amyloidosis, which was mainly glomerular. And you can have, like the one on the left, this was a case of amyloid A, which usually targets blood vessels like glomeruli and so on. So patients with amyloidosis, not all patients with amyloid are nephrotic or have enlarged kidneys. Immunophenotyping with the amyloid deposits is required, so in order to guide management and prognosis. Now, patients with EL do receive chemotherapy now and are dealt like malignant patients. Cardiac involvement will differ according to the type of amyloidosis. In AL/primary amyloid, these patients actually die out of heart failure before the renal failure. Whether if it's a hereditary amyloidosis like trans-13, for example, it does affect the heart, but it does not damage it as quickly as AL. So it's very important now to do our best to phenotype the type of amyloid. Again, amyloid is not always an isolated renal disease, and Ian has just shown you in his talk in diabetes how some patients with diabetic glomerulosclerosis have superimposed amyloid disease. And we see superimposed amyloid on all types of systemic diseases, on top of nodular glomerulosclerosis, on top of FSGS, and so on. So it can be superimposed on pre-existing renal diseases, whatever it was, and lupus, and so on. So the report from the pathologist should include other pathologies, because this is what's going to influence the patient's management and prognosis. A patient with primary amyloid is different, or with AL amyloid is going to be managed differently than this with AL amyloid and diabetes. So other pathologies are always important. So I'm going to sum up with this trial from a conjoint effort between the Mayo Clinic and the RPS to try to make a consensus report on pathological classification, diagnosis, and reporting of GN and how things should proceed. And according to them, they had classified glomerulonephritis on the basis of etiology and pathogenesis, not on the basis of morphology, into 5 major categories: immune complex, mediated pulse-immune, anti-GBM, monoclonal, and Z3 glomerulopathy, and I add membranous as well to it, personally, because we do phospholipase and thrombospondine, and we can have an etiological pathogenic diagnosis. This is just an example of how they think the report should be, whether you comply to it or not, but the bottom line is that within your pathology report, you should have a clue to the pathogenesis, if the pathologist can get to it, of the disease, the pattern of glomerular injury, because necrotizing patterns with crescents are different from patterns with focal and segmental sclerosing. If there is a score or a grade of the activity and chronicity, then it should be mentioned. Any additional features, because these are the prognostic features of your patients and they should be included. And if you have kindly provided us with proper clinical data, then these clinical modifiers can also be included in the report, as well as secondary diagnoses. Bottom line is that in the report, it's not only the number of glomeruli and it's not only the diagnosis. Read the descriptions. Your prognostic factors will all lie inside tubules, interstitial blood vessels, and that's really the power of the renal biopsy. Thank you very much. This is the zoo in Cairo, and that's the view of my office. Thank you.